All right, future nurses, gather round. When you're stepping into that pediatric unit, one area that demands, well, your sharpest focus, where the stakes are incredibly high and your vigilance can quite literally change an outcome, is pediatric cerebral dysfunction. This deep dive is built entirely for you. We've pulled from key nursing textbook sources to zero in on what you absolutely need to know about why things go wrong in the developing brain, the pathophysiology, the signs and symptoms you'll actually see, the critical nursing care interventions, and the treatments, including the medications you'll be giving.
It really is. It's a field that's both complex and honestly immensely rewarding. Children, especially the youngest ones, they can't always tell you what's wrong, so your ability to assess, to recognize those subtle cues, and really understand the why behind them is just paramount. Early recognition here is absolutely everything.
Exactly. So consider this your essential toolkit, ripped straight from the pages. We're going to unpack how we assess the pediatric neurological system, identify those big, scary complications like increased intracranial pressure, walk through specific conditions from head injuries to infections and seizures, and then finally sort of synthesize the core nursing management you'll apply across all these challenges. Okay, let's jump right in by unpacking the foundation, the central nervous system. This command center in your brain and spinal cord, it orchestrates everything, right? Breathing, heart rate, consciousness, movement, sensation. When it's dysfunctional in kids, the source material makes it clear the causes are incredibly varied. We're talking trauma, infections like meningitis, tumors, metabolic issues, or even congenital problems they're born with.
And what's absolutely critical for you as a nurse, I think, is recognizing that the signs in children, particularly infants, are often just vastly different from adults. They can be subtle, they can be nonspecific, and they can change really rapidly. This is precisely why your assessment skills are, well, they're your superpower in pediatric neuro.
And speaking of assessment, the source material really emphasizes that the most important indicator, the one you check constantly, is level of consciousness, or LOC. But how do you get an objective handle on that in a child who, can't just answer questions like an adult?
Right, and this is where tools like the Pediatric Glasgow Coma Scale, or GCS, become just indispensable. It standardizes your assessment
Yeah.
of eye-opening verbal response, which is tailored for age. Obviously, you're not expecting an infant to tell you their name, and motor response. It moves you beyond just a gut feeling, to a score you can actually trend and communicate clearly.
Okay. Beyond LOC and GCS, what other assessment key points are vital?
Well, definitely look at the pupils' size, equality, reaction to light.
Mm-hmm.
Are they sluggish, pinpoint, maybe dilated? These tell you about pressure on specific brain areas. Vital signs are also huge clues. A changing heart rate, blood pressure, or respiratory pattern can really scream that something is happening centrally. You also need to assess reflexes, and it's important to distinguish between normal, disappearing infantile reflexes and those abnormal pathologic ones that shouldn't be there or persist. That indicates neurological trouble.
Uh-huh.
And then there's posturing decorticate, with the arms flexed and legs extended, or decerebrate, where all four limbs are extended. These are, frankly, grim signs of severe damage. Recognizing which type of posturing is present gives you insight into the level of brain involvement.
Right. Here's where it gets really high stakes in pediatric neuro. Increased intracranial pressure, or AICP. This isn't a condition itself, right? But a dangerous complication that can pop up for many of the problems we'll discuss.
Exactly. Think of the skull like a fixed, bony box, especially in older kids and adults where those sutures are fused. Inside that box, you've got the brain, blood, and cerebrospinal fluid, the CSF. Now, if any of those components increase significantly, say, from bleeding after trauma or swelling around a tumor, excess CSF and hydrocephalus, maybe swelling from infection, there's just nowhere for the tissue to go, so the pressure inside the box rises. The source lists trauma, tumors, hydrocephalus infection as common culprits.
So, as the nurse at the bedside, what are the early warning signs what you absolutely cannot miss? The source points to things like headache, often described as severe vomiting, frequently without nausea, which is kind of a key differentiator sometimes.
Right.
Increased irritability or restlessness, and maybe just subtle changes or a general decrease in LOC.
And this is a really critical point for infants. Because their fontanelles are still open, the skull can expand a bit. So in infants, you need to look for a tense or bulging fontanelle, an unusually rapid increase in head circumference, and that classic, very high-pitched cry. The late signs of air ICP are truly ominous bradycardia, so a slow heart rate, and Cushing's triad.
Ah, yes, Cushing's triad.
Which is that combination of a rising systolic blood pressure, a widening pulse pressure, a dropping heart rate, and irregular respirations. Eventually, as pressure becomes critical, you'll see fixed and dilated pupils. It's a very bad sign.
So, recognizing those early signs is really your first line of defense. Management involves basic things like elevating the head of the bed, maybe 30 degrees, to help promote venous drainage and limiting stimuli. But the source also details specific treatments to actively reduce ICP, things like osmotic diuretics.
Like mannitol, yeah. That's used to pull fluid from the brain tissue back into the vascular space. Corticosteroids might be used, especially if the swelling is related to tumors. And sometimes, like with hydrocephalus, surgical intervention like placing a shunt is necessary to drain off that excess CSF and relieve the pressure.
Okay, so some of these concepts, like how pressure physically builds inside the skull, or maybe what's actually happening electrically during a seizure, they involve understanding some fundamental mechanics that can feel a bit abstract sometimes. To really nail down the why behind these critical signs and symptoms, let's bring in our special expert for just a moment.
Hi there. Yeah, think about the skull just like a sealed container. Inside, you have the brain tissue itself, the blood flowing through it, and the cerebrospinal fluid cushioning it. These three have to exist in a very delicate balance. Now, if you add more of one, maybe bleeding from an injury or extra CSF because it's not draining properly, something else has to give way or the pressure just goes up. The brain tissue itself is soft, right? So increased pressure physically compresses it against the hard skull, and that reduces blood flow to parts of the brain. That lack of oxygen and nutrients is what causes many of the symptoms you're assessing. The changes in LOC, the pupillary responses, the vital sign changes as the body tries desperately to keep blood flowing against that rising pressure. Now for seizures, think of it more like an electrical storm inside the brain. Normally, brain cells communicate using controlled electrical signals. A seizure is like those cells suddenly misfiring uncontrollably, really rapidly, causing this cascade of abnormal electrical activity that can spread. It disrupts normal brain function and leads to the symptoms you see, like the muscle jerks, the altered consciousness, or other strange sensations. Understanding this helps you see why the goals of treatment are things like controlling swelling, maintaining blood flow, or using medications to sort of dampen down that excessive electrical activity.
Thank you so much to our special expert for shedding some light on those crucial mechanisms. Understanding the why really does make the what of assessment and intervention much clearer, doesn't it?
It absolutely does.
Okay, let's transition now to some specific conditions you'll likely encounter, starting with, unfortunately, common head injuries in childhood. The source helpfully categorizes these for us.
Yes, starting with the most common, concussions. These are transient functional disruptions. The key point here is that even if the child doesn't lose consciousness, symptoms like confusion, amnesia, headache, dizziness, they all mean the brain has been impacted, and the management is crucial. Cognitive and physical rest really let the brain heal.
Then you have the more severe ones, contusions, basically brain bruises or lacerations, which are actual tears in the brain tissue. These can cause more specific neurological deficits like weakness on one side, what we call hemiparesis. They can definitely increase ICP and trigger seizures.
And skull fractures are important because they give you a clue about the force of the impact and the potential for underlying injury. Linear fractures are common, usually don't need specific treatment, but a depressed fracture, where the bone is pushed inward, that's a key one because it often needs surgery to lift the bone fragment and protect the brain underneath.
Right.
Basilar skull fractures, those at the base of the skull, are also critical to recognize. They carry a risk of CSF leaking from the nose or ears, and you might see those classic signs: bruising behind the ear, the battle sign, or around the eyes, raccoon eyes.
And then the hematomas, the bleeds inside the skull. The most urgent point here, I think, is knowing the difference between epidural and subdural. Epidural hematomas are typically arterial bleeds located between the dura and the skull. They develop fast and are a true surgical emergency. You need to act quickly. Subdural hematomas, on the other hand, are usually venous bleeds under the dura. They can develop more slowly, sometimes over days. This is why they are sadly common in infants after trauma, and sometimes, because the symptoms aren't immediate, they can be mistaken for non-accidental trauma or abuse. Recognizing that subtle, delayed change is just critical.
That's fascinating, isn't it? Exactly. That the timing of when the symptoms appear relative to the injury can give you vital clues about the type of bleed you might be dealing with.
Yeah.
Frequent neurochecks are just non-negotiable with any significant head injury.
Okay, moving on. Brain tumors are actually the second most common childhood cancer. The source mentions specific types like medulloblastoma, astrocytoma, and brainstem glioma.
And the key point here is that the symptoms depend heavily on where the tumor is located in the brain. Classic signs that might trigger imaging, maybe an MRI or CT, include a persistent headache and vomiting, especially if it's worse in the morning upon waking. Also, an unsteady gait, new onset seizures, or maybe just unexplained behavioral changes. Diagnosis involves imaging and usually a biopsy. Treatment can involve surgery, radiation, though that's used cautiously, especially in kids under 3, and chemotherapy.
And the nursing care. It involves that vigilant monitoring for increased ICP we keep talking about, implementing seizure precautions if the tumor is irritating the brain, and of course, providing immense emotional support to the child and the family who are navigating this incredibly difficult diagnosis and treatment journey. Hydrocephalus is another condition where those fluid dynamics are key. It's basically an imbalance in the production, flow, or absorption of cerebrospinal fluid, the CSF.
Right. You'll see it described sometimes as communicating, which means there's an absorption problem, or non-communicating, meaning there's a blockage in the flow somewhere, perhaps from a tumor or a congenital narrowing like aqueductal stenosis.
And the key thing for hydrocephalus is recognizing how the signs differ so drastically with age. In infants, where those fontanelles are still open, you'll see a bulging or tense fontanelle. You might measure rapid head growth that crosses percentile lines on the chart, and you see those classic sunsetting eyes where the irises seem to be pushed downward.
Exactly.
Whereas in older children with a fused skull, the rising pressure shows up more as headache, vomiting, and maybe changes in vision or eye movements. The primary treatment mentioned is often surgical placement of a ventriculoperitoneal shunt, or VP shunt, which drains the excess CSF usually down into the abdomen where it can be absorbed.
And post-op shunt care is a really critical nursing responsibility. Often you'll position the child flat initially. This is to prevent draining that CSF too quickly, which can cause its own set of complications, like a subdural hematoma. Your key role is monitoring constantly for signs of infection fever, redness along the shunt tract, and also shunt malfunction.
How do you spot malfunction?
That would be the return of their original hydrocephalus symptoms, things like headache, vomiting, irritability, maybe changes in LOC. That's an emergency. You need to report it immediately.
Got it. Okay, moving to infections. Meningitis and encephalitis are really serious. Bacterial meningitis, in particular, is a true medical emergency requiring rapid action.
It absolutely is. The key for bacterial meningitis is having a high index of suspicion with that classic triad in older kids. Fever, a stiff neck, what we call neutral rigidity, and altered LOC, often with photophobia, sensitivity to light. In infants, the signs are less specific, but crucial to spot. Things like poor feeding, lethargy, irritability, maybe a bulging fontanelle, and that high-pitched cry again.
And the causes?
Common culprits include group B strep in newborns, and then Neisseria meningitis and streptococcus pneumonia in older infants and children. Diagnosis relies on a lumbar puncture. Looking at the CSF, you'll see cloudy fluid, high white blood cells, low glucose because the bacteria eat it, and high protein. Treatment is immediate, aggressive IV antibiotics, usually respiratory isolation initially, and definitely seizure precautions.
Okay, and then there's viral meningitis.
Right. Viral meningitis is usually less severe, often caused by things like enteroviruses. The symptoms are similar, but generally milder, and it's managed supportively. Hydration, pain control, usually revolves on its own.
And encephalitis, that's different, how?
Encephalitis is inflammation of the brain tissue itself, not just the meninges covering it. It's often viral, maybe herpes simplex virus, HSV, or West Nile virus. The key difference is because the brain tissue is involved, symptoms are more likely to include significant altered LOC, personality changes, and seizures, along with the fever and headache. Diagnosis often involves MRI and analyzing the CSF with PCR testing for specific viruses. Treatment is mostly supportive, however. IV acyclovir is specifically given for suspected or confirmed HSV encephalitis because that one is treatable if caught early.
Okay, let's touch on Rice syndrome. It's rare, but the source mentions it as severe. Acute encephalopathy plus liver dysfunction, and it's strongly linked to using aspirin during a viral illness, especially the flu or chickenpox.
Yeah, this one is scary because it can progress incredibly rapidly.
Yeah.
Symptoms often start with just vomiting and lethargy, but can quickly deteriorate to seizures, coma, and dangerous cerebral edema. Labs will show significantly elevated liver enzymes and ammonia levels. Management is intensive, requiring ICU support, managing that ICP very carefully, and general supportive care. The absolute key for prevention is simple. Avoid aspirin in children, especially during viral illnesses. Use acetaminophen or ibuprofen instead for fever or pain.
Good advice. Okay, seizure disorders, another major area. So a seizure is basically an abnormal electrical discharge in the brain, and epilepsy is diagnosed after, 2 or more unprovoked seizures more than 24 hours apart?
That's right. Let's look at the types mentioned in the source.
Yeah.
You have generalized seizures affecting both hemispheres of the brain. Tonic-clonic, sometimes called grand mal, is the most dramatic.
Yeah.
Loss of consciousness, body stiffening, that's the tonic phase. Then the jerking movements, the clonic phase, usually followed by a period of drowsiness or confusion, the post-ictal state. Then there are absent seizures, sometimes called petit mal. These are brief, sudden lapses in awareness. The child might just look like they're staring blankly for a few seconds. These are pretty common, actually, a key thing to recognize in school-age kids. Focal seizures start in just one area, one hemisphere of the brain. They may or may not involve loss of consciousness, and sometimes people experience an aura beforehand, like a strange smell or feeling.
And febrile seizures.
Ah, yes, febrile seizures. These are common in young children, usually between 6 months and 5 years old. They're linked to a rapid rise in fever, not necessarily how high the fever gets. While they can be absolutely terrifying for parents to witness, the good news is they're usually benign and don't typically cause long-term brain damage or mean the child has epilepsy.
So as the nurse, your management during an active seizure is a really critical skill. What's the priority?
Safety first, always. Protect the airway, gently turn the child on their side if possible to help drainage. Clear the area of any hard or sharp objects to prevent injury. And importantly, never put anything in their mouth. You could cause injury or obstruction. Then observe and document meticulously. Note the start and end time. Describe exactly what movements you saw, any color changes, their breathing pattern, and how they recovered afterwards. That information is vital for diagnosis and treatment planning.
And medications.
Medications are definitely key. For acute ongoing seizures, the sourceless rescue medications like rectal diazepam, often given by parents at home, or IV lorazepam in the hospital setting. For long-term prevention in kids with epilepsy, maintenance medications are prescribed. Examples mentioned include phenytoin, valproic acid, and levetiracetam. A huge part of the nursing role here is educating families on the importance of medication adherence, taking it exactly as prescribed, and also teaching them when and how to use those rescue meds if needed. Having a clear seizure action plan is vital.
Okay, finally, let's talk about cerebral palsy, or CP. The source defines this as a non-progressive disorder. That seems important. It results from some kind of prenatal or perinatal brain injury, and it primarily affects movement and posture. So the key is non-progressive. The initial brain injury doesn't get worse over time, but its impact on motor development is permanent.
Exactly. There are different types. Spastic CP is the most common, characterized by muscle stiffness and tightness. Dyskinetic CP involves involuntary movements, like twisting or writhing. Ataxic CP affects balance and coordination. And it's really crucial to remember that kids with CP often have associated conditions too, things like seizures, sensory deficits, vision or hearing problems, or intellectual disability, though many have normal intelligence.
So management is complex.
It's truly multidisciplinary. Physical therapy, occupational therapy, speech therapy, these are foundational to help maximize function. You'll also see orthotics like braces being used, medications such as baclofen, often given via an implanted pump to reduce spasticity, or maybe Botox injections into specific muscles. Sometimes surgery, like tendon release procedures, might be done to improve mobility or positioning. Your role as the nurse is often coordinating care, supporting the family in navigating all these therapies, and promoting the child's highest possible level of function and independence. So, pulling it all together now, while all these specific conditions obviously vary quite a bit, the core nursing management principles you'll apply across the board are really your ultimate toolkit. Performing those meticulous neurological assessments, consistently checking LOC, GCS, pupil response, being hypervigilant for the early signs of increased ICP, implementing seizure precautions whenever indicated, ensuring airway patency, adequate hydration and nutrition. These basics are always important. And critically, providing education and ongoing support to the child and their family as they navigate these often challenging diagnoses, while always focusing on safety and promoting developmentally appropriate care.
Wow. Okay, that was a really thorough deep dive into what is clearly a complex and absolutely critical area of pediatric nursing. From understanding why certain signs appear to recognizing those key differences between conditions and knowing your essential nursing actions.
Yeah, this really underscores the profound responsibility and the potential impact of the pediatric nurse. Absolutely, it does. Your observational skills, combined with a solid understanding of the pathophysiology and the potential trajectory of these conditions, they're just invaluable assets in providing the best possible care for these very vulnerable children.
Remember, you are often the first one to connect those subtle dots. Maybe it's just slight irritability, or a change in feeding pattern, perhaps a little asymmetry in movement you notice, your informed assessment makes all the difference.
So this raises an important question for you to consider as you reflect on this deep dive. In a busy clinical setting, maybe things are happening fast. When you observe a subtle neurological change in a child, how does drawing on your understanding of the specific pathophysiology of the potential underlying conditions actually help you prioritize your next assessment steps and anticipate the necessary interventions?
Definitely something to ponder as you continue building your expertise. Thanks so much for joining us for this deep dive.